This webinar hosted by the Pankey Institute. It's a pleasure of my good friend Ken Miller and I are going to co-host this evening. It's a real pleasure of ours to be with you, and hopefully we can create some good dialogue and exchange some ideas and learn from one another. So what Ken and I'd like to do is share a little bit about the relationship we've developed professionally. I'm a general dentist. Ken's an orthodontist in my community, and we've had the pleasure of working together now for 20 years, I believe. We practice in a relatively small town of about 60,000 people in eastern North Carolina. And I like to joke with my colleagues that it's kind of like living on Noah's Ark. We have two of just about every specialist. And Ken is one of the wonderful orthodontists that we have an opportunity to work with in the community. Telling you a little bit about my background. I practice with my wife, Amy, and we've been in the community and practicing now for 32 years together. And we recently brought on a new associate who's going to become a partner this fall. So we're really excited about that, Dr. Drew Gorham. And then you see the ladies that make up our internal team there in the practice. And I like to think of the teams we work with are certainly these ladies who make us shine, but also the team of specialists that we've developed a network with throughout our community as we work to help our patients achieve excellent results. I'll let Ken provide his own introduction.
Yeah, so Ken Miller, I graduated from Chapel Hill in 2007. That was dental school. And then I stayed in Chapel Hill for 3 more years for my orthodontic residency. And so actually, Richard, I guess we've been practicing together for about 12 years now and I joined a practice that my father had for many years. In fact, if you look at that photo with me with my team, there are 4 or 5 of my team members that have been there since I was 5 or 6 years old, and they're still there today. So it is a small community. You can see the top photo. That's my wife. She's actually a pediatric dentist in our town. And I'm also busy juggling those 3 that we're holding in that photo. And just doing some braces in Rocky Mount, trying to help out.
Yeah, you do a great job. As I reflect, I graduated a little bit longer ago than Ken, 1989 for myself from UNC, and moved to Rocky Mount and took over a practice for retiring dentists. But as I reflect on the last 32 years of my career, one of the most rewarding parts has been developing relationships with the specialists that we work with and developing that network so that we can provide the best care possible in our community for our patients. Tonight, we wanted to talk a little bit about just what those relationships look like and how are they created, how are they nurtured, and how are they celebrated. And so we're going to touch on these objectives. Certainly, how do we develop and why is it important to have an efficient and effective network so that we can have good, predictable outcomes for our patients? And then, how are we going to create and nurture a win-win relationship so that the specialists and the GPs really feel energized and rewarded by the relationship. Moving on, talking about a collaborative care agreement. Ken and I will share how we use this document as a communication tool to build the rapport that we have between our practice and his. And I'll even share how we do that with other specialists in the labs that we work with. And then lastly, it's, how are we going to celebrate the outcomes that our patients have and hopefully increase the quantity and the quality of referrals. And we'll touch on that referral pattern goes both ways, not just from the general dentist to the specialist, but also from the specialist offices back to the restorative dentist practice. So that's a bit about us. When I graduated from dental school, this was, as a general dentist, this was what I felt I needed to be, sort of the jack of all trades, or the old Swiss Army knife, that whatever came through the door, I needed to be prepared to handle. And that was what a general dentist was tasked to do. I soon learned I did not have all those skills, certainly. There were some things that I enjoyed more than others, some procedures. There were some things that I had colleagues that were better than I am at. And I knew that no matter how hard I worked, I was not going to have the expertise of a specialist. And so begin to think about it in a different way, and that really this concept of interdisciplinary care and how do we work with a team so that we've got a team of certainly involves a restorative dentist, but we have an endodontist. On my team is a periodontist, an orthodontist, Ken and his father, oral surgeons, and then I would include the laboratory that we work with as well. And really at the center of all this is the patient. And so how can we, in these 6 different disciplines, work synergistically so that the patient can have the best outcome and not feel like they've been torn in 2 different directions. So football season's upon us in just a few weeks, I think, kickoff. And so you can relate to the concept of a team working together, and you got to have a playbook. And certainly working with a specialist, we've got to understand what is the outcome and what are our roles on that team. I like to think of myself as the quarterback of the restorative plan, but I've got a lot of really special role players on my team. These role players who are much better athletes in their respective areas of practice than I am. And so relying on them to execute the plays, but all of us have got to know, well, what's the other one doing and how can I count on my colleagues so that we can, have a winning result. It may be just as simple as this is a patient that Ken and I shared, a young man. You can obviously see peg laterals that need to be restored. But in talking with Ken about where we'd like to position those laterals so that we can have an excellent restorative outcome with some conservative veneers. And so Ken is wonderful at communicating with me along these lines. He will often have a patient like this prior to ever completing treatment, whether they're in brackets or Invisalign, coming to have an occlusion check, and we're talking about angulation and position of the teeth. And what I love about Ken is he's so receptive to making changes and tweaks. The last thing either one of us wants to do is to have the patient feel like they've completed their treatment, and yet then we're saying, well, we actually need to revisit things.
Yeah, and
or maybe, yeah,
Richard,
Ken?
I was just going to say that we all look at the case with our own treatment bias, and the way I look at things aren't exactly maybe the way you look at things. And since you ultimately are delivering the result, I find it very important to get your okay before I pass them back to you.
Yeah. And thanks. And there are times when I may say, well, Ken, can we move this tooth to this position? And I don't understand the orthodontic concept. So he'll explain to me why, maybe if I do this, I'm going to give up something else. And so it's a trade-off. We have this conversation about, well, how can we create the best result possible, given what the patient presents with.
That's right.
Another patient that Ken and I shared, she's obviously got a reverse smile line. A beautiful woman, but didn't like her smile. She had some erosion and attrition issues going on. Certainly some extrusion had occurred. And so working with Ken, first we sat down and talked about what we wanted where we wanted the incisal edges to be, where we like the gingival margins to wind up. And so he worked out the orthodontic care to intrude the teeth and level and align the incisors as well as the gingival margins. And with just mocking up and then completing some porcelain veneers for her, we were able to get an aesthetic result that was both aesthetic and functional, and that the patient was happy with, Ken was happy with, and certainly we were real happy with. So Ken, you did an excellent job working with
thanks.
that.
Those are always when the gingival zeniths are uneven and teeth have super erupted as they've kind of chipped and worn. You kind of got to make the problem worse. So one of the things that y'all helped me with is kind of, as it was looking worse, as we were leveling her centrals, y'all would kind of add a little bit and make her feel better. So that was an important part of our communication too. Yeah,
lots of back and forth. And she's been a great referral source for both of our practices. So we certainly appreciate that. So it's really about, the efficiency and the effectiveness of the treatment that in working with your specialist. And so that both sides kind of understand what's possible and just have that dialogue. And so we're going to talk tonight a little bit about, well, how do we communicate? What are some of the formats that we use? We've got the 4 learning objectives. I'd like to stop after each topic and offer to answer any questions that you want to put in the chat box. If you pose any, we can answer them now, or we can wait till the end. So I'll give you a few minutes if there's any questions that have already come up.
Let's see. think we're good so far.
We're good. You know, I failed to say that at the beginning, in the chat box, there should be a start code that you'll want to write down so that you can get your CE credit. So look in your chat box for that. I believe Desi's supplied it. Okay. So talking about, you know, so how do we create and how are we going to nurture this win-win relationship from both perspectives, from the GP's perspective and the specialist? And, you know, I think it goes beyond just having a relationship professionally, but getting to know the people, being trying to develop social relationships as well. We had a oyster roast, and you see an oral surgeon, an endodontist, and 2 periodontists that we work closely with in this picture. And so you can see, obviously, we like to have a good time together, but it's not all about, Ken, I know as a specialist, oftentimes specialists provide gifts and so forth as ways of building their referral networks. Can you talk a little bit about how, as an orthodontist, you develop the people and create relationships with people that are around you in the community?
Yeah, sure. You know, I was fortunate enough that my father had been in the community for, I guess when I got there, probably 35, 36 years. So I just kind of had to keep the train on the tracks. But what I see as important to developing these relationships is being available to everyone. And whenever I get emails or phone calls, I encourage everybody to reach out to me at any time, because the faster I can get back to them, the better they feel about, you know, picking me is being the person that helps them out. So being approachable, open lines of communication, and always being open to helping out is what's helped me out, to be honest with you.
Yeah. You know, reflecting back on when you finished your training and moved to town, moved in with your father, who we had worked with previously as well, I reflect and say there was certainly a transfer of trust. I know he was your dad and you were his son, but I would think in any specialty practice, you're going to have often younger doctors come in. And I think it's important, these long-term relationships that have been established with maybe a senior doctor, that doctor be cognizant of how they can transfer trust to the younger member of their team, the newer specialist or younger specialist, just like we do with, you know, our associates and younger docs that come into our practices. Right. And so that's really crucial as well. And so one of the mechanisms that Ken and I have developed is creating what we call a collaborative care agreement. And I use this with not just Ken, but all of the specialists and laboratories that we work with. And it was, you know, our goal certainly is to have seamless referrals. When patients leave our practice and they're going to be sharing care and receiving care in another practice, then we'd like for that referral to be like a well-oiled handoff, and the patient not to be dropped in the middle. But unfortunately, sometimes it's like a tug of war, and you find that 2 different practices who haven't communicated are pulling in different directions. And obviously it's the patient that's caught in the middle and feels like the rope in this picture. And so how can we make it as seamless as possible so that our patients can go to another practice and receive care without feeling like they're just layering on, yet having to tell their story one more time, or that there's not good communication from one practice to the next. In my learning at the Pankey Institute as a student, I often heard the term, we were taught about position papers. And I've just reframed that. And the idea was that you would create a document with your specialist that we like to call our collaborative care agreement. And it really is just about what do we need to do and learn from one another so that we can provide the very best care possible for our patients? What is it you need from me so that you can do your best work, and vice versa? And how are we going to do this, not just most effectively, but also how can we do it most efficiently for ourselves and the systems within our practices, but also for the benefit of our patients? And so in creating this document, we created a framework. And what you see here is what Ken and I developed. And we each took this paper, and these are just the different categories that we agreed were things that we should cover and talking about. And so certainly you see that the purpose is just improving care for the mutual patients and facilitating communication, and then understanding one another's expectations. As we all know, unclear expectations are disappointments waiting to happen. So kind of clarifying those expectations on the front end helps diminish disappointment at the end. Our philosophy of care and our our practice is shared with each of the specialists and labs that we work with. We talk about our philosophy of occlusion. We talk about how patients are going to be, how that initial referral is going to be made, what records might be shared, email addresses, communication regarding treatment progress. How often do I want how often Ken can provide an update regarding the patient's treatment progress. And things as simple as just fill me in, Ken, what hours, days are you in the office, so that we can better prepare our patients for what's available. We talk a little bit about fees, because oftentimes when I propose going to have a consultation with the orthodontist, the patient will ask me, well, can you give me an idea of ballpark? What kind of investment is this, if I'm thinking? So I always try to, Ken, I always try to go on the high side for your behalf, but it helps me to kind of have an idea. And so it's good wanting back and forth. Same with the patients asking Ken about veneers and how long might this take and what would be involved. And so we talk about that, and we talk about how our practice is going to handle fees and assignments of insurance benefits. What are we going to do around preventive care while patients are going through active orthodontic treatment? You see, of course, fluoride. Our philosophy of anterior guidance, what that means and what we strive for our restorative cases, how extraction is going to be handled if there are necessary, a patient that Ken is deemed we need to remove teeth. We, of course, talk about various modes of care, Invisalign, who's going to handle third molars, how we're going to do those at what time, what's retention going to be like after active therapy is finished, and who's going to be responsible for providing which appliances and monitoring those appliances. Certainly, what about our TMD, our patients that suffer from TMD and benefit from Splint Therapy? And then, of course, dental sleep medicine has become something that all of us have to look at and look for and diagnose in our patients. And so this was the framework that Ken and I sat down, and each of us took time to fill in this. And then we met together at lunch one day and just went over each of the categories and filled it out. As you see here, our practice philosophy is to treat the centricalization or the most stable condylar position. So we talk about that. How is that referral going to be made from our practice to Ken's when that first phone call? Who might we have on the other end of the line, and what kind of information would help him, what they'd like to have from us? It might be as simple as, if we have a panoramic, how recent does it need to be? If it's 3 years old, 4 years old as Ken, can we let the patient know that Ken's going to be taking a new radiograph? How we're going to share those back and forth with one another. For our relationship, we agreed that we're usually going to offer an orthodontic referral to most children around age 7 or 8. And Ken helped educate us as to why it would be important for him to have an opportunity to see these kids maybe before they're really ready to begin active treatment, but to identify problems before they get into their real growth stages. And certainly what our observation is going to be like. And so this is the framework that we shared. We talked about the things that are going to be going back and forth. Our practice writes a letter. We don't just include the clinical, what we like clinically, but we try to provide a background about the patient, a little bit about the person attached to the dental condition.
And I would just chime in on that and say that is, as from a specialist perspective, having that information from them is huge, because I mean, many times I walk into the exam room and a patient that, not referred by the Hunts will just hand me a note from their previous dentist, and I'll look at it and they'll say, please evaluate for ortho. And I kind of look in their mouth and they're missing several teeth and all of that. And so, then I start asking them questions. Were you planning on replacing these or those? And they'll be like, I don't know. They just told me to come here. And so it just leads to a kind of a choppy start. Whereas if Richard or Amy sends me a patient, they'll tell me a little bit about them. And, she's got 2 daughters. One of them just graduated from college, and this is our plan for her is for you to do this. And then we're going to implant here, here, and here. And so when I walk in, it's almost like it's just an extension of the other practice. They feel like, oh, okay, he knew I was coming. He knows me. Everything's more comfortable, and it's so much better than somebody handing you a sheet of paper saying, evaluate, please. Sorry.
No, thank you. I appreciate that. So Ken, from a specialist perspective, I guess you get all types of referrals. As you just said, you got your referral pads that many offices just have at the front desk, like you say, hand to the patient. What's your experience as a specialist? Would you say generally, what do you get from practices?
Actually, most of the time I don't even get a piece of paper. I'd say 70% of the time they say, my dentist just told me to come, and then a lot of, as a specialist, you feel good when you see person referring and you realize it was an old patient. And so, an old patient sending, but there are very few dentists that give the detail that help me and the patient feel comfortable right off the start. That doesn't happen a lot.
Do you feel like it does it? I guess in one way, is the bar higher so that you feel like, oh my gosh, this is now more of a pain in the neck of the stuff I've got to pay attention to, or does it help you be more efficient with having this information?
Oh, absolutely. It helps you be more efficient. I mean, you connect on the personal level. You've heard that saying, nobody cares what you know until they know that you care. And you can have that conversation quicker, and you can tell that people all of a sudden they're much more comfortable about being in this strange place with this random guy. It makes it much more efficient. You're in the exam room a shorter amount of time, possibly sometimes, because they just trust you and they know that you're going to do the right thing because they were sent by people that they trust. And they can feel it because I already know some of the things that the only way I know it is if you tell them.
I find it does help us be a lot more efficient. It cuts down on the back and forth of, well, did Dr. Miller get, or would you call Dr. Miller's office and find out
exactly
from him what happened? It's usually, because he's provided a great report back to us and update reports. And so all that information is provided, and we're not spending time back and forth and kind of searching it when the patient's maybe back for a recare visit. Yeah. And certainly just things as simple as, how we're going to communicate, email addresses, what's going to happen, when are we going to receive communication during the treatment as it progresses. Ken is great at this. We'll generally get, some feedback after the initial exam and at their recare visits when they start treatment, and then annual progress updates. And certainly before debanding, Ken, you almost always are having any of the adult patients return for us to take a last look before the appliances come off or the active treatment ends. And I think that really the patients really appreciate that. And I know it goes a long ways in tweaking the restorative plan.
Like you said earlier, there's nothing worse than finishing something, or you think you're finished, and then they show up 3 months later and they say, oh, by the way, I needed another 1.5 millimeters. And I'm like, wait, what? I didn't know that you were doing this or doing that, and it's because of poor communication. So, I mean, it's better off to avoid all of that, get it okay, and then move on. Everybody's happy.
Exactly. We talk about things just so we can prepare, our patients for our expectations of them as well, regarding preventive care while they're in their appliances. Ken understands what our goal is around anterior guidance with our patients to get coupling and overjet and overbite if possible, so that we can get good anterior guidance. How extractions are going to be handled. We do a small amount of Invisalign in our practice, but it's only for restorative cases as adjunctive treatment. I'd say we defer 99% of the care to Ken because of his expertise. But Ken, I got to say, one of the great things is you've been so willing to look over our shoulder if there is a simple tooth movement case, and say, hey, you got this and I've got your back. And that means a lot to the restorative dentist.
Absolutely.
And so Splint Therapy, we talk a lot about, how we're going to handle TMD therapy for these patients. Retention between us generally will be a mandibular bonded retainer for a lot of the teenagers, but all of our adult patients are getting Hawleys unless they request the bonded. And then many of them are going to have an occlusal guard that might serve as a retention as well. But, I can imagine how important it is for Ken to know that this is a patient that when we finish orthodontic treatment, they are going to be moving into an occlusal splint, a hard splint that's going to serve as a retainer in that arch. So he knows, well, okay, I've got retention handled in that area, and we're going to make maybe an upper, what do you call it, with a bow and without wires that are going to interfere with the occlusion. And so, again, helping our patients.
Lots of times, yeah, lots of times we'll tweak this. You'll email me and say, hey, instead of doing an upper Hawley this time, can you do a lower Hawley? I'm going to make her an upper splint. The lines of communication are always open. So, but it's great to have a guideline, because I know if I don't hear from y'all, what you're expecting out of me.
Okay. And then certainly we talk about dental sleep medicine, the patients that we're going to screen all our patients for that, but that we do have an interest in helping patients that have sleep disorder breathing issues. And really the overall concept that we want to really make clear is that we're really seeking comprehensive care for our patients, and that every patient presents with a unique set of circumstances, unique temperament, and unique goals that they have. And so how are we going to tailor their care to that individual? And so it really is trying to help both sides, help the patient keep an idea of a focus on what the big picture is for the outcome. And as Ken knows, often many of the adult patients, as soon as they get started, they're ready to get done. And so him being able to remind them, hey, this is part of an overall plan here. And so just reminding them of that. But this last conclusion is, it's really about trust and mutual respect between the individuals and between our offices, between our teams, that with open communication, the best interest of our patients can be served. And so we get together once a year and review this, as Ken said, tweaking it regularly. But it just opens the avenue for communication. So I would encourage you to consider doing this with the specialists in your community, those that you work closely with. So Ken, can you talk a little bit about a specialist? If you had never had this approach and we're not receiving this, and a doctor came to you and said, I'd like to sit down and talk with you about my philosophy of care or how we can work best together, how would you receive that? Is that, I would assume.
I would receive it really well. And I would encourage everyone who's listening, we can't see all of y'all, but your specialists would like to hear from you. Richard and Amy were so good. As soon as my wife and I kind of moved to town, they had us over for dinner and immediately made us feel comfortable. And we started talking about these kinds of things. And I can't thank them enough, but I promise you that if you feel like your specialist is standoffish or not approachable, they would love for you to have this kind of thing with them, because lots of my friends in bigger towns, they don't have this kind of thing, and it does lead to communication breakdowns. I hear their stories all the time, and they will flat out say, I wish they would just call me and tell me this. But so I welcome this kind of thing, and I would encourage all of y'all watching to get with your specialist, because I promise you they would welcome it as well. That's what I'd say about that, Richard.
All right. Well, thank you. So in a moment, we'll talk a little about, why don't we share, this is a patient that Ken and I had an opportunity to care for together. Jim, you can just look at his smile and face and tell what an amiable, lovable guy he is. Jim did not come with aesthetic concerns, but during his initial preclinical interview and comprehensive exam and kind of co-diagnosis experience, he learned more about the things that were a bit out of place, how he could benefit from orthodontics, not only from an aesthetic standpoint, but really from a functional standpoint, and how long-term he could perhaps have less dental care necessary if he chose comprehensive care. And so Ken and I sat and took all the diagnostic information and sat together and looked at the mounted models and photographs and talked about what it was that Jim was was hoping for. He was missing an upper left bicuspid, so we knew an implant was in the works. But he said, I'd always noticed, some chips on my teeth. I thought it was just really some of my bad habits. But we began to look more closely and talk about long-term and what potential complications could occur if we didn't do something to unravel those lower incisors and create not only better guidance, but better access for cleansability. After now 32 years of practice, I see patients in their 80s with this type of scenario, and I'm thinking, boy, if only we had done something before, that we wouldn't be trying to treat the caries in between numbers 26 and 27, or we're losing teeth and so forth. So sitting down and talking about, beginning with the end in mind, so to speak, was talking about what we wanted to accomplish for Jim, where we wanted his incisal edges to be, so forth. So Ken did a really nice job of aligning things, keep creating space for the implant, really just getting things in a good position so that our restorative plan was really just conservative resin bonding to replace what had been lost in many areas. And so now Jim was able to get a more attractive smile, which he is very proud of, but it really took minimal restorative care to bring him to this place. And but it took a lot of communication between Ken and us as he went through care to get him to this place. But we couldn't have a more raving fan, I would say, than Jim. He's ecstatic. And Ken, you just did a great job of caring for him. So it was where Jim began and where he wound up. I think we all could say he's going to be better off long term, not just with a bit more attractive smile, but functionally and access to cleaning and maintenance is going to be much, much better. And so nowadays in 2022, the reviews are mighty prevalent. This was one that Jim wrote about his experience between Ken's practice and our practice. And interesting that he says, Richard describes himself as the quarterback of the team. And so he talks about the team that we've developed, not just in our internal staff, but Ken is the orthodontist and the periodontist that we were working with for the implant placement. And so he talks about, he was aware we took impressions, pictures, and explained the steps as we go along the way. Wasn't really sure whether he wanted to pursue this at first, but after talking about what could be done, he began to have confidence in pursuing the treatment. And he began to understand the preventive nature of orthodontics and the implant. And so he said about having a treatment plan. He says here, Dr. Ken Miller was a delight and fun to work with. I can promise you all our patients say that. Ken's lots of fun, but really a delight to work with. Dr. Arrington, periodontist, was superb, making herself available anytime to answer questions. Looking before and after the braces were taken off, didn't realize how bad things were until we got things straight. Can't say enough to thank Dr. Richard, Dr. Ken, and Dr. Harriet for their care. And then he talks about, when I deliver training to our corporate customers, I think about the service I expect and receive from Dr. Hunt and his team and try to match that level of quality. And so I share this not to toot our own horns, but really it's about the relationship that Jim recognized between the three offices, the periodontal office, the orthodontic office, and the restorative office, to help him get a result that was both aesthetic, functional, and maintainable for a long time. So if you're looking to grow your practice, it's people like Jim you want out in the community telling stories about you. But I couldn't have done it without Ken and Harriet and the excellent job they did and being on the same page to help him get to that place.
Richard, we do.
And so I was going to say, before moving on, any questions about developing an agreement?
Well, here, this is Christopher Spain. He says, orthodontist here. Curious to ask how you would manage Essex retainers and splint wear. Who makes and owns the splint and does the touch-ups? How do you alternate with Essex wear and splint wear since they can't be worn together? Obviously, substructure. I'll do a holly to avoid occlusal crossover and facilitate more splint wear, but I don't do a ton of hollies due to relapse tendencies of rotations. So I'll just say, Christopher, that we don't do a lot of Essex with splints, or I don't with Richard. They're always, if they're doing a splint, they do all of those, and they do their touch-ups, and I'll do the Holly. And you know, you're right, Hollies do have some little kind of rotation tendencies. I do put acrylic on the bow to kind of help with those as best I can, but we typically, I don't do a lot of Essex with splints. Richard, you can.
Well, yes, I was gonna say what we've learned together and developed was those bows that didn't have the acrylic were less reliable, and so we began adding the acrylic. I call it like a bumper, but yeah, to certainly help align those. In our practices, Amy and I make all the bite splints and refine those for the patients. So we're doing that, but in coordination with Ken doing the retention and the opposing arch. And again, it's not an Essex, it's usually a Holly of some sort. It could be a bonded. If we're maxillary, we might have a bonded lower anterior.
And I do tell them too, Christopher, to take that Essex and put it in a very special spot, just in case we ever need it, to wear it for a couple of weeks to kind of tidy back up or something. So
that's the reality.
Yep.
Other questions posed?
No, I think we're good. So I think we're good.
We're good?
Yep.
Okay. So, you know,
okay.
How are we gonna?
Here's one other one, Richard, sorry. What if you and the specialist don't agree? For example, both do sleep or frenectomies. You talk it out. That's how we would handle it. I don't know that we've really run into a disagreement yet, but go ahead, Richard.
I would agree. Well, for instance, the periodontal office we work with makes bite splints for their patients, but they do it because a lot of the referring dentists don't do that for their patients very much. They want the periodontal office to make the bite splints, and so, but yet because we've talked it through, they understand that we've spent a lot of time developing our experience and skill around that, and so we're going to be the ones managing the patient. So in that regard, we make all the bite splints, but we just had to talk it out and talk about why it wasn't going to be a splint that was fabricated in the periodontist office, because we would be maintaining and responsible for looking after it long term. But I would say it all comes down to communication. It's not about, you don't want to feel like a tug of war, or it's not about who gets to do what. It's really just, hopefully you can find a way to agree. Hopefully not to have to disagree, but that you can agree upon who's going to handle which procedures for which patients, or just that both of you have it available.
Yeah, and I would chime in that as the specialist, I mean, I kind of feel like the hired guy to get a job done. Like Richard said, he's the one who's going to see them, you know, for the rest of their life, essentially, especially adults. And so I stand down and let him do his thing. If it ever came to that, this hasn't become an issue with us by any means, but I would, you know, he's ultimately, he's the quarterback, you know.
Well, but I will say, I really try not to be my way of the highway kind of approach. This is about collaboration, yes. And then I'm open to that.
Yep. Oh, here's another one. Why don't you use lower Essex retainers with upper splints?
In our practice, because we can't control the occlusion on the bite splint with an Essex in place like we can with the precision of the cuss tips. And what we're going to strive for is, you know, not just stable contacts, but also smooth excursions and protection. And so we can't do that with an Essex on top of the teeth as well. So we like to have the teeth against the splint as opposed to plastic. Can you speak to it?
Yeah, that's exactly the way I feel about it as well. You know, with an Essex, one Essex is not the same to the next, you know, it depends on how long it stayed over the heat and what the vacuumer's doing that day. So it's a little too unpredictable to be able to do something that accurate. Richard, somebody says, can you comment on the importance of the staff from specialists and generalist offices developing a strong professional relationship so our offices communicate and work well with each other as patients go back and forth between offices?
Yeah, thank you. Great question.
Yeah,
And
that is.
wouldn't you agree? I mean, because many offices, these ladies have conversations every day,
Oh,
and yet they don't. Many times they don't know what the other person looks like, and so we've intentionally, gotten together with our teams and made sure that the front office, the people that are having these conversations, have visited with one another. I know when our new associate moved to town, first thing he did was go around with somebody from our front desk, and she introduced him to the specialist front desk, and it was just a great way to make that introduction. But I think it's critical to the success of the relationship to have synergy between the team members as well. Never hurts to provide, a Chick-fil-A platter and go by and help take care of these people who help take care of our patients.
yeah, that's right. Again, we're kind of in a small town, so a lot of our staffs, they do know each other, and so it's kind of easy for them to be friendly with each other. They know each other's names, and they've kind of known each other for years. So we're lucky in that aspect. Richard, are you up for more questions?
Sure.
Here is this collaboration more challenging in competitive markets? Any advice on helping colleagues see the bigger picture, grow the pie versus fight over the slices?
I can't speak to the bigger markets, only by hearsay. I can imagine that, though maybe in a larger market, if I'm a specialist, then I want to there are a lot of dentists that could refer to me. I would like to create a referral network of quality rather than quantity. And so likewise, if I'm a restorative dentist, then I don't want to have 8 orthodontists I can refer to. I'd like to have a couple, 2, 3, and that work out geographically, that we all think alike and are willing to, not everybody's willing to take this approach. And so who's willing to be collaborative and communicative about things?
Yeah, I would think from a specialist standpoint, if I were in a very competitive market, I would certainly welcome this type of thing, because the closer you get to these people, the more you feel like you might actually get some of their referrals. So from my standpoint, I would be more open to it. Okay, I think we're good.
Okay. So I talked earlier about, the referral process, and it really is a two-way street. We often think, certainly as that new graduate who thought he had to be the Swiss Army knife and there was something that I was going to refer, it really was a slip of paper and send them to the specialist, because who knew better and knew what to do, and they would send them back whenever they were finished. But recognizing that that the communication has to go both ways, but also the referrals can go both ways. And so Amy and I are intentional about asking our specialists, those that we work with, for referrals and recommendations. We came to Ken's office and brought lunch one day and had a overview, shared some cases of patients that they had helped us care for. And so we showed the restorative outcomes so they could have a better understanding of what we do for the patients we've shared. And that engenders more confidence they have in us, and therefore has led to many more referrals from the specialist offices. Ken, can you speak to the idea of as a specialist, do you have patients that are seeking a referral to a restorative dentist?
Oh, all the time. A new family will move to the area, and the oldest teenager will already have braces on, and they'll have 2 other kids, and the mom, it's time for clean. So this, every day, somebody comes in who needs a dentist, and I send y'all a lot. I tell everybody about y'all. Yeah. So that, your specialist, it's not just a one-way street. um, when you're referring to them, they start to see a lot of your work, and they're like, oh wow, I mean, Richard and Amy are just unbelievable dentists. So I always feel confident sending new patients to them. A lot of my people find me on the internet or whatever, and they need a dentist, and I send them right on over. So it works both ways.
Well, we even took it a step further in developing these referral cards. And so, as you can say, one of the finest compliments a practice can receive is referral of family and friends. We printed these and took them and sat with our specialists and said, look, if you know of people that you feel would be a good, that we would be a good match for and that we could help, we would welcome those referrals. And I would just encourage any of the general practitioners that are on this webinar to not be hesitant to go and speak to your specialist. If you would like to have some good referrals from these specialists, then go out and ask. It's not unheard of at all. And it can really be very much a practice builder for you. And so, Ken, you guys have been great at this. Thank you. But we try to make it as easy as possible. So we have these cards and he's got a stack of them at the front desk, and it may not be him that gets the question, but somebody, his business assistant that has somebody ask about it, and she's got this available, and she goes, well, here, this is somebody I can recommend to you.
Richard, you have a question.
Okay.
Harry's asking, can you please discuss collaboration with MDs, especially for sleep apnea treatment and certain protocols, if you will? I guess that would be more of a question for you, because
yeah, well, that's a whole nother webinar likely with the status of dental sleep medicine. But I would agree, and that is so much. If you're going to treat these patients, there has to be good collaboration, good communication between the medical providers and the dental providers, because of course, as dentists, we're just treating a medical condition with a dental device oftentimes, and so that communication is paramount. And the better your record keeping and what you can share going back and forth is going to engender much better referrals from the medical specialist to you, and they're going to have a lot more confidence in you helping care. I hear from a lot of medical providers the skepticism of dentists that want to, they say, jump on the bandwagon, so to speak, and are they willing to really to do what they need to communicate and monitor and follow up the care for these patients. So I'm not an authority in that regard, but I would think it's maybe even more paramount than some of our dental specialists that we work with.
Could you comment on how you describe the referral process to your patients from GP to specialist, and your relationship with the specialist, the ease of care between practices, etc.? So the referral process, I guess, Richard, like when you realize somebody might need my help, how they get to my office.
Okay, well, it begins certainly with a conversation with raising their awareness about their needs. And so once they have either expressed the desire or we've helped them understand the benefits of how orthodontics could be a part of their overall care, and they're receptive to the idea of orthodontic treatment, in which we often tout the benefits of really leading to less restorative care. Often, if we can move the teeth in a better position, we're going to have fewer restorations and less care, which is in the long term, maybe it's going to save them financially and certainly save them tooth structure. And they're often receptive to that. But once they're on board, and of course, we speak so highly of Ken and his team, and so we tell them what to expect. We make the phone call. The initial phone call is made while the patient's in the practice to Ken's front desk. They receive the information, and they go ahead and arrange that a first visit. Ken, understanding that he's going to get all the pertinent records that we've agreed that would be helpful for him to provide, anything I have, as well as a summary of the patient's, not only their dental condition, but their maybe their personality and anything that might be pertinent to help him know that patient better before they even arrive. So it's made while the patient's in the practice. We really want to cut down on, minimize the hurdles the patient has to jump over to make these visits. Because often I'll have patients say, really I don't want to go to 4 different offices. The medical model, oftentimes patients feel like they're passed around from one doctor to another. And in this case, we're just trying to say it's almost like Ken's just practicing down the hall here. And I just want, because of his expertise, he's on our team, and I would really think you'll benefit from meeting with him. So that's how the referral process goes. And once, Ken, can you explain, once you've met with the patient and done an exam, how you communicate back to us?
Absolutely. So again, yeah, so they'll send me a little information about the patient, and not just their dental stuff, also a little bit about them, which helps me. And they'll also tell me about their motivation a lot of times, like, by the way, this guy does not care about aesthetics. So that helps me, so I don't go off on some tangent about the way something's going to look to somebody who doesn't care about it. So then I'll see him, and I walk in with all this knowledge, and it goes smoothly that way. And I'll kind of look in there and be like, okay, well, this might be difficult. This might be difficult. So I write y'all a letter, and I'll also send you an email lots of times, especially if it's something that I'm concerned about. I do a letter and I'll do an email, which, I hope that's not annoying, but it helps me know that the story, like Richard said, it's almost like it's just right down the hall, because I've been given the story and they know I know the story, and so I report back on the next step of it. And it does make for a very efficient process,
Yeah. For those patients that have more complex restorative needs, we will actually meet and look at photographs, models. We like to do that before the patient ever meets the patient. So you can imagine when they show up with the first visit, he goes, yeah, I've already met with Dr. Hunt, and we looked at those molds of your teeth, and we reviewed the pictures, and he's told me it just goes a long ways of them accepting treatment and buying in, or them having kind of that transfer of trust we were talking about.
Yeah, absolutely. Somebody wants to know what size your referral cards are.
It's gosh, what are they? It's like a 4x6. It's not real big. I think a 4x6 card. Had them made. The back side has a map to the office, but of course nowadays everybody just goes to the website or Google's the address. But it's just something. It's just an easy thing for the other teams to utilize.
Somebody says, how would you as a specialist approach a GP who refers to you who seems to do consistently sloppy dentistry? Yeah. So I guess we've all been there. That's tough. I mean, I've had a phone call several times, saying, do you mind if I do anything to this ledge, or hey, I'll kind of phrase it as, hey, I think little Billy might have accidentally chipped one of his fillings. Do you mind taking a look at it? And so they can kind of get a second chance at it. That's always awkward. And I take that, each situation is different in how I handle it, but that's a good question, and it's never fun. Sorry to not have a great answer, but there really isn't a great answer.
Well, that's a delicate conversation.
Yeah, exactly. It is.
Yeah.
You just, I feel it out. And, on occasion, there have been few occasions where if a situation kind of hasn't resolved very well, somebody might ask me, well, who else do you know? Where else should I go? And you never want to be the specialist. And I know what you're thinking. You never want to be the guy who's sending the patient somewhere else. And you don't, but sometimes I do. I'll be honest. Sometimes I do.
Fortunately, it's a minority, right? I mean, it doesn't happen.
It doesn't. No. Yeah, it doesn't happen often. It doesn't happen often. Somebody says, how much is the referral fee for GPs?
I'm not sure what kind of fee. I don't. There's no referral. I don't get any kickback from referrals that I make, if that's the question. So there's really.
Sorry, Richard, I've been shorting you on that one, bud.
Yeah, there you go.
Yeah, so we don't have a referral fee. Okay, we're good on the questions.
We're good. Okay. Well, so
Hey, Ryan.
sounds like we've already posed. We'll see if anybody's got questions as we wrap up. We got about 5 more minutes. I wanted to provide everybody with our emails. Kim and I would welcome you to reach out to us if you want to talk one-on-one or want to request some information that expand on what we've talked about this evening. You will all receive a recording of this from the Pankey Institute, I believe tomorrow. And so just you can look for that as well. But it's been our pleasure to be with you tonight. And I hope it's that you picked up 1 or 2 pearls that will help you care for your patients in a more effective and efficient manner. I know, Ken, I can't thank you enough for just the job you do day to day and helping us, but in agreeing to come on tonight and be part of this webinar for the Pankey Institute. It really means a lot.